Hi everybody, my name is Bree and I'm an ICU nurse at a Northwestern hospital here in the Chicagoland area. My first thought after watching this video is just thank goodness there's something like this out there. One of my other jobs at my facility is I do work on the Nurse Peer Review Committee, which is a committee in our hospital that reviews cases that were either high risk or that did end up in an adverse event with the patient. We review them from a nursing standpoint. It's colleagues of the whole hospital represent a unit just to review the case to primarily see if care is appropriate, but also if there's processes that we can change to eliminate errors that happened. So after seeing this video and of course hearing Dennis Quaid talk about his circumstance, which I was aware of as well, I think that it was a really helpful and useful video for the general public. It was put both in layman's terms as well as really clear for healthcare professionals, as well as how important this topic is for patient safety. I think oftentimes when we hear of errors or maybe even make errors ourselves, we don't always think about the lasting effects on patients. We always kind of think very in the moment, like, oh my gosh, this is happening. So one of the takeaways that I had, or lasting impressions, was really watching how this affected people, not only in the moment or during their hospitalization, but discharge and the rest of their life, and even how some of these errors did cause a fatality, which changes a family's life forever. So in our ICU, one of the areas that we have worked on and the areas of improvement that we have is with administering our paralytics or our neuromuscular blockers. We did have an instance, so with it being COVID, we are doing what a lot of hospital facilities are doing right now, which is keeping our pumps outside of the room. We do know with our COVID patients that are ventilated that oftentimes their lungs are so stiff and hard to ventilate that we do end up medically paralyzing, or you're using a neuromuscular blocker medication such as atracurium to paralyze the patients in order to have better vet compliance and overall better outcomes for the patient. Well, this past year, during the midst of COVID, when things were really crazy and us as ICU nurses were having 3 to 4 patients per nurse at a time, there was a nurse that did end up getting both a pressor agent known as Levofed in a bag that was brought up and mixed, and a neuromuscular blocker known as atracurium. Both were mixed by pharmacy, both were in bags. They didn't look too different from each other. Actually, I mean, the labels for the patient were different and labeled correctly. It was just that the nurse had them in her hand. And so with the pumps outside the room, we scan the patient bracelet that's attached to the pump because that patient is assigned that pump. She scanned the bracelet and then scanned both medications, which both were scanned correctly for the correct patient. The problem came though, something crazy was happening on the unit. She had 3 other patients, and I believe one of our patients wasn't doing very well, that she quickly spiked the medications and ended up swapping the IV line. So the pressor agent was going through the lower rate of the paralytic pump side, and the paralytic was going through the pressor agent, which was going at a much higher rate. So what ended up happening is not only did this patient's blood pressure drop, but the patient was actually more paralyzed and less sedated, which is a practice that we do not do at our hospital. If the patient is going to be sedated, if the patient is going to be paralyzed, they absolutely are going to be sedated. It was actually another nurse that discovered this error at shift change. So this whole time, I mean, the patient was having issues with their blood pressure, up, down, up, down. They ended up adding another pressor to it. But as this was happening, The other nurse realized that the bags were swapped, and obviously we needed to put in a risk report and it needed to be reviewed, and we needed to ask ourselves what needed to change about this process, because this should not have happened. We had all the safeguards in place, the medication scanning, the 5 rights. I believe she even went through all of the rights and then had to put the meds down for a second, run and do something, and then just quickly spiked. Probably should have rechecked it, but didn't, because she was confident, because she went through all the rights. And what we ended up doing now, how we changed our processes, is through better, more accurate labeling. And as I was reviewing literature for this week as well, there is a study which I will post the reference of. You can view in my post, but it's called Paralyze by Mistakes, Reassess the Safety of Neuromuscular Blockers in Your Facility. It was a study done by Matthew Grissinger. And according to the study, which again you can refer to at the bottom, the most common type of error with neuromuscular blockers appears to be administration of the wrong drug. A 2009 analysis of 154 events over a 5-year period showed that neuromuscular blockers were not the intended drug in approximately half of all wrong drug errors. So this isn't something uncommon. It's more common than it should be. However, this isn't something uncommon. A lot of nurses do have, or there has been a lot of drug errors in regards to paralytics. And they broke down the reasoning as to why. And one of the main issues was having to do with labeling, the vials looking very similar. So in our ICU, obviously, it had to do with bags, but in a lot of different ICUs, surgeries, everything like that, that may require neuromuscular administration, neuromuscular blocker administration, is they use vials, and they reconstitute the vials and give it that way. So one of the things they were discovering is like vecuronium, one of our paralytics, has a very similar label to flumazenil, which is what you use to reverse opioids. And then vecuronium also can have a similar label, depending on the manufacturer, to a vial of vancomycin. And as you can tell from both of those, that they are very different from being a paralytic. And once the caps are removed, these vials look very similar. However, the mix-up of these could be absolutely catastrophic. There's a couple of other things that they mention in here, such as accidentally swapping your syringes, having just a knowledge deficit in these areas of using a paralytic if a nurse isn't used to doing that. If there's residual drug in the tubing, like they do in like OR, a nurse could try to save the hospital money by using that tubing, but ultimately not clearing that line and administering additional paralytic at a higher rate accidentally, which could ultimately cause the patient harm. So because these serious events continue to occur, the study did say that some adequate safeguards would be, they actually did come up with a answer, like a best practice recommendation, which if you click on this study, they have a hyperlink to. It's called Targeted Medication Safety Best Practices for Hospitals, and it aims to promote the safe storage of neuromuscular blockers in order to reduce risk of harm from these drugs. And one of the things specifically for my hospital that they ended up doing, like I was mentioning earlier, was relabeling these medications. So instead of having like your big bag of potassium chloride and your atracurium both come up at the same time, or all get tubed in the tube system, and they just hand you a bunch of meds and say, here you go, here's all the meds that you had for your room. They've now started to hand deliver paralytics to the nurse that is supposed to deliver them. Nobody can sign for you. And then they have a big pink label on them that says caution paralytic on them, right underneath the patient label and on both sides. So that if it's flipped, you can't accidentally say, well, I didn't see the pink sticker. They make it very obvious that this is the medication on this side, and this is a paralytic, and this is not. So that's one of the ways that in our hospital we've tried to eliminate errors that could potentially cause patients harm. obviously there's many, many ways. Um, but overall, just to kind of summarize, I think that this is a very important topic to go over, and especially from the side of looking at it from a legal perspective for the hospital. I see it both from a nurse error, being a nurse myself that is practicing at the bedside, and the legal portion, and there is gaps. And I think the best people to fill those gaps are the ones that are on the ground doing the work, and that's nurses. And so, yeah, I think we have a big role to play in this.